So, good morning, everybody. In continuation of the cervical spine injury, this is fourth class, I believe. We have discussed a lot regarding the basic anatomy of cervical spine as a whole, biomechanics of the spine, and also different movement, etc. We have also discussed about the craniocervical injury. Already mentioned that craniocervical part is a bit atypical. This area, particularly occipito-atlas junction, is mostly maintained by soft tissue membrane. And in this area, if there is a dislocation or injury, it is very catastrophic many times, because immediately you have the very vital structures, the respiratory centers and sensors over there. It is why it is one of the causes of your instantaneous death in a trauma situation. However, while going down below, in C2, particularly you have already mentioned, there what are the fractures we are supposed to get in C2? We have discussed already, just refreshing it. There are the fractures of the odontal process, the hangman fracture that involves you supposed to know. We have discussed the things. Hangman fracture, dislocation is very dislocated anteriorly, that is also going to do some damage. We had already discussed about the rotational instability of this area. Rotational instabilities are one point of one way it is better in the sense that most of the time it doesn't cause much neurological deficit. Are you getting my point? Rotational. It is rotational, so canal part is somehow maintained. If there is dislocation, it is always catastrophic. I repeatedly telling you that these things are very important. That is why you supposed to have a very good concept about this. Cervical spine. So that is why I have taken so many classes. So you supposed to have a very good idea about the injury in the uppermost level, craniocervical area, and injury pattern in the subaxial area is somehow different. I have already told you that actually the exaggerations of these basic movements is one of the culprit. So you have lateral flexion, you have excessive flexion, right? You have extension, you have excessive extension, or you have lateral bending also. These are pure movement. Pure means your axis of trauma. But it may also combine with other processes, particularly rotation. The flexion, rotation. Yes, pure flexion may be there. Pure flexion may be there, or flexion along with rotation. Or you remember, suppose somebody hitting like this, and his head is like this, so impact of the force is called more rotation. Yes, then again axial compression. Suppose somebody is falling from height directly on head, a diving, particular diving, yes, or something is falling on head. That is a compression force. So now today's class is basically subaxial area. We have already discussed about this. I have already told a lot of things about this subaxial area. What are the things there? So in the subaxial area, what are the trauma? What are the trauma? Trauma is flexion. So flexion may cause what? What sort of injury you can expect? What? Compression. Try to understand that it is not a one-way game. You have to also take part. So while I am calling like this, compression, like this, compression, flexion, what is going to happen? What is going to happen? It is going compression. So compression, fracture of the anterior body is because of the flexion. One point. If the flexion is more, what is happening? What is happening? Posteriorly. What is happening? Distraction. Very good. So if you look it up here, if there is more flexion here, anteriorly, necessarily, there is a distracting force of posteriorly also. So that will cause the injury to what structure? What structure? It will cause injury to PLC, combined link. What is PLC? What is PLC? What is PLC? This is not one-way game. I will tell you and you will listening from this side and throughout this side, no. What is PLC? I told you this thing. Huh? What are the things there? What are the structures going to fail from the posterior side? Necessarily supraspinous ligament firm. Then interspinous will open up. Then if it is going more and more pain, and it will open up to that. So that is a stable situation and unstable situation. It is unstable situation. Instability is there while there is injury both anterior posterior. So in a situation while there is a compression of the vertebra here and equally opening up, what is this? Is a good situation or bad situation? Bad. So bad situation may be good if the compression is less. So if that is why it is also important that if there is significant compression in the X-ray, what is the meaning? That posterior also equally opening up. More decompression there, that is why from the radiological point of view also one can take the X-ray from lateral side. If the reduction is more than 50%, it is good or bad? It's good or bad? Say loudly, good or bad? Bad. Why bad? Why bad? It indicates that it is more compressed, more opening up, more tear in the posterior side. If it is less than 20%, say 20%, 30% only, what does it mean? Is it compressing? It may not cause. So indirectly also from the X-ray lateral view one can make out that what is the extensivity of the posterior side. Got my point? Yes or no? Okay. If it is happening more compression, what next is going to happen? That is told already. What is next? What is next? One is called theodore fracture. So the vertebral body will be fractured in the inferior part. So it is compressed between the two. What my point? Yes or no? Yes, sir. So supposing these are the two vertebrae here. So if it is compressed like this, what is going to happen? There is a compression there. At one point of time, there may be a fracture in this inferior part. That is a good sign or bad sign? That is a bad sign. That indicates that there is distraction posterior also. If harder compression is taking place, what next going to happen? There will be dislocation of the vertebra, right joint, because it will open up. Yes or no? If the dislocation is happening and is going translocation, going anteriorly, what is next? What is going to happen to the cord? It is going like this. Suppose it is fractured. There is a fracture here. It is like this. Down. What is going? It is opening up. It tests there. This is going like this. Yes, it is going like this. There is a fracture here. Then there is a tearing of the fracture. Then it is. What is going to happen? What is going to happen to cord? Not translation, but it is compression. So it is a good sign or bad sign? Bad sign. So that is the importance. So the theodore fracture, if you get, there is a fracture there that you are supposed to know that there will be extensive injury to the posterior structure. Yes, sir, this is not a good thing. So it is a flexion. I am talking only flexion type. So extension of the same thing may happen. Okay, sir? Then supposing, so you just think that reverse things are happening. In reverse thing is happening, what is going to happen? Means opening up. What are things going to fail? What is the anterior structure here? What is the anterior structure here? What is the anterior structure here? What is the anterior structure here anteriorly? What is this? What is this? Yeah, what? Anterior? Anterior? Anterior longitudinal ligament, yes. So there is the anterior cervical ligament here. It is going to fail. If it is going like this, what is the structure going to fail? Supraspinous ligament, interspinous ligament. Ligament of flavor, all going here, opening up, more here. If reversing is happening, what is going to happen? Hey, master, what is going to happen? What is the structure anteriorly? What is the structure anteriorly lying to the body? Anterior longitudinal ligament. Say loudly. Anterior longitudinal ligament. What is the structure? Yes, it is opening up. What is going to happen to the ligament? It is tear. It is tear. If it is tearing more, what is next going to happen? Where will be the injury? Where? Where will be the next injury? What is going to tear now? What is next structure? What? What is going to tear? Next time you are not improving now, I will deal with us badly. This is not going to happen again. What is the next structure? What is the next structure here? To move to. Body to open the heart on the heart. So it is the disc. So what is this structure? So all the discs will tear. What is this structure going to tear? What is going to hold the disc? What is going to hold? What is holding the disc? What? You stupid fellows or something. So next structure is going to tear is the annulus. Because annulus is the joint which is holding the two bodies. So anterior longitudinal ligament tear. Then it is opening up. Next structure is here. Then what is next structure? What is next structure? Body is not because if a distracting force is working, sometimes there may be a avulsion flexor here. Because of this, just like your avulsion flexor of your middle malleolus or lateral malleolus. But if it is opening up like this, what is the structure first going to tear? Then annulus flexor. Then what is this? Posterior longitudinal ligament. Posterior longitudinal ligament. Yes. Then it is open up. If it is more open up, you may also go for sliding like this. Now tell me what is happening to the posterior structure. Pars intra-articularis is what is this?
The posterior
what is going to happen in the posterior structure? Compression of what? What? Spinous process, because all these are crowded. Now what is happening? These are crowded. They are pressing each other. So what is going to happen in the posterior? What is going to happen to the bone? If it is crowded like this, each other, what is going to happen? What? Fracture of the spinous process. So if it is opening up like this, see, it is opening up like this. What is happening here? The distracting force is working here. So these spinous processes will be crowded each other. So it will press each other and lead to fracture of the spinous process. Now, this patient, while you are doing X-ray, you will find he is going back. But posteriorly, you will find there is spinous process fracture, 3 and 4 spinous process fracture. Only X-ray, what is your inference? Lateral view X-ray showing there is fracture of the spinous process 3, 4, 5, they are fractured. But again it is coming back alignment. From the X-ray, what is your inference? What is your inference? What is your inference? It is a hyperextension injury. So from the point of view of the X-ray, you can tell that he may come back. So opening a whiplash injury, he is going back. Suddenly, the steering of flexor spinal process, again he is coming back. Now while he is coming to the casualty, you are taking X-ray. So X-ray shows there is a flexor of the 3 spinal process of 3, 4 and 5. What is your inference? Hyperextension. These things should be clear. Yes. So this is a POD. So from the X-ray one can make out that if it is flexion type, you suppose to have compression. But if it is extension type, you have a distraction for anteriorly, compression for posteriorly, and that lead to your outing of the spinous process may lead to what? Fracture of the spinous process. It may come back again. When taking the X-ray, you will find the processes are fractured. There may be minor avulsion fracture in the body because of ligamental pull attached to it, as we see in case of median malleolus or lateral malleolus. Understood? This thing to be clear. Now, another point is there. Supposing the person is like this, you are getting like this. What is the situation? What is the situation? Now there is another injury I am talking. Subcervical, subaxial. That this side here, this side, this body is going like this. This is what? This is what? Dislocation of what? Diacetyl joint. If it is happening this side, you say it is what? Right-sided. Right-sided dislocation. There are two things you may have see. It may be bilateral. It may be unilateral. It may be subluxation. It may be dislocation. These things mostly happen in what condition? Where you find? While there is a rotational injury. While there is a rotational injury, supposing it is rotated like this. There may be a flexion type of fracture also sometimes. Suppose associatedly there is what? Compression. Yes, but if it is purely like this, but there is no fracture over here, this is what? Rotational injury. आपका मूव ऐसा घुरा दिया दूर से, तो rotational injury होगा. Yes, sir. In rotational injury, what is the thing going to happen? The dislocation. So if it is rotating towards the left side, so what joint is going to fail? Which joint going to fail? Right side. Right dislocation. So if it is happening left side, it is your right side rotation is left side. So if it is happening, so how do you express this? Dislocation of CT, C4 or whoever might be left. Now, next thing is that sometimes, as I say, in flexion type, flexion distraction, going like this, it may slide over the both the joint over here. What is this? How do you express it? How do you express it? It is said bilateral dislocation of so and so vertebra. C3 over C5, C4, C5 over C6. When dislocating or suppose this is C5, this is C6. If it is going like this, how do you express it? Bilateral dislocation of C5 over C6. Yes. What next? What next? So this is hyperextension. So you're supposed to understand these things. These are very important. And do not get confused with so many classifications. There are many classifications are there. It is true. And sometimes it is confusing also. It is true that none of the classification fulfill all the criteria. So that is why it is evolving every day. Something new are coming up. But try to understand the basic thing. What may happen? Pure thing, not very, very complicated one. One should understand that if there is going like this, what are the structures going to fail? And most of the time, it is the X-ray going to tell you a lot of things. X-ray going to tell you a lot of things. Whereas certain things unable to delineate it in this simple X-ray. That is why you may need to go CT scan and MRI. Why MRI is important? Why MRI is important?
Body. Body.
Pardon?
Ligamental
injury. Suppose in PLC, see in a why it is called unstable. While there is an injury both sides, it is very unstable. Suppose the injury is happening one side, it is most of the time stable because other structures are going to hold it. But if there is injury to the PLC as well as the anterior structure, it is an unstable situation. So a unstable situation most of the time, okay, X-ray can help you to know, but it is also true that MRI will you later better about the situation of the disc also. As I said, in a sliding one, translation. While translation, disc which was engulfed by the annulus is also torn. Now this is free. If the free disc is there, sliding force is there, this disc may go this way, that way also. Yes, this disc may be the cause of your compression of the cord. Then it is the cause of your neurological deficit. But in this situation, X-ray is not going to help you because X-ray cannot tell you about the soft tissue structure. That is why also it is very important to know about the ligamental structures, soft tissue structure, condition of the disc. All these things are very important. So that is why only one investigation tools are not enough to give out the picture. Even doing only investigation also, sometimes it becomes difficult to explain the situation. Sometimes you may get so many devastating injury, but neurologically is very silent. Sometimes you get less injury, but less injury in the X-ray or the investigation, but neurologically the deficit is very high. So these situations are difficult to correlate and explain. So many, that is why so many things are happening. But as of now, this thing to be clear. Now I have explained 3 points. One is your flexion, one is your extension, one is your rotation. I also told you that there will be combination of the flexion and rotation, extension and rotation. Okay? What next? One is called vertical compression. Vertical compression, you will find what sort of flexor is supposed to get. Burst flexor, very good. Burst flexor. Now, burst flexors are a bit dangerous also. This is stable burst, unstable burst. Burst flexor is defined from the, one should always must have a very good concept. What is called burst flexor, what is called compression flexor. You should not have any confusion here. Compression flexor is here while the body is involved. Anterior part is compressed. Something is compressed. But in this situation, your posterior wall is still intact. That is very important. But in case of burst flexor, got my point? Yes. In posterior wall is broken. That is called burst flexor. Sometimes it is difficult to delineate both these things together. So that is why CT scan is helpful. So this is a dangerous situation because if the wall is broken posteriorly, the free fragment may cause compression to the cord here. Understood? Understood or not understood? Yes. So this fragment may be a cause of your compression. So burst flexors are not very easy. Someday in the stable burst situation, but it may cause compression to the cord. So that is happening most of the time axial compression. These things should be clear. Okay, sir? So purely try to understand the basic things, not only complicated one. What are the mechanism of injury? The compression. What should be picture here? Flexion. What should be picture here? Extension. What should be picture here? Rotation. What should be picture here? Okay, sir? So these are the possible injuries. Now, now patient is coming to you in the casualty with a history of trauma in the cervical spine. What next you are going to do? So one basic thing in ATLS point of view, the irrespective of any situation, you're supposed to immobilize the cervical spine, so that you do not do undue movement of the cervical spine. Undue movement of the cervical spine may lead unwanted consequence with neurological deficit, irreversible neurological deficit. Because while he is coming to you casualty, he still do not know what is the extensivity of the cervical spine. We presume that he has injured his cervical spine, that is why we do not want to do. Because wrong transportations of the patients also a contributor of your neurological deficit. Wrongly transported. It is a good contributor to the ultimate neurological deficit and the consequence. Once it is damaged, it damages forever. Okay, sir? That is why. Next thing, then, treating the patient from the ATLS point of view, we are not going to talk. Now, in the cervical point of view, what next? What next you are going to do? What next? There are two situations. One, that you may exclude the cervical spine by clinical examination. It's the exclusion of the cervical spine. There are Canadian criteria and certain criteria are there. And all the patient which is coming initially presumed to be cervical spine injury, immobilize the cervical collar, but subsequently evaluate that whether this patient need to undergo any investigation or not. It is not necessary. Suppose road traffic accident, ATLS guideline, yes, apply. But next, it is not logical to do unwanted investigation to a person which is not needed. Yes, so in this situation, that is called exclusions of the cervical spine by certain criteria, like why the patient is conscious, why the patient is not intoxicated, why the patient can able to have a good orientation and can able to do movement of the cervical spine without any pain. And also you are palpating the cervical spine, there is no tenderness or there is no neurological deficit. So these things you have to remember. So you have to remember that the cervical spine, presumed to be cervical spine injury, should to be evaluated again to confirm it whether he need to go for investigation or not. So in this situation, there is exclusion. Patient is non-intoxicated, fully conscious, well-oriented, no neurological deficit, can do free movement of the cervical spine in tenderness, and a palpation, there is no tenderness. This is called exclusions of the cervical spine. Okay, sir? Now, next group is there that pain is there. That another group may be two types. One, who is having some cervical injury without neurological deficit, and another group is coming with a neurological deficit. Two groups. Okay, sir? These two groups needs investigation. Those patients who is having neurological deficit is one category. These are two again. Neurological deficit group again two. What two? One is complete neurological deficit, another is incomplete neurological deficit. But one should always understand that initially the patient is coming with may come with neurological shock, spinal shock. So at this time unable to speak, tell us the truth about the actual injury to the cervical neurological status. So in this situation, you have to wait till the spinal shock is over, then do the calculations on the Frankel grading or ASIA grading nowadays. So grading you have to categorize A, B, C, D, E. That is neurological point of view. Another point of view that you have to go for what? The investigation of the cervical spine. So what are the X-ray you are going to advise? What are the X-ray you are going to advise in the casualty while coming a patient is coming with a trauma, cervical spine injury? What are the X-ray? It is enough or something more is needed? Do you know what are the investigations should be done in the cervical spine or do not know? Do you know or do not know? Yes, sir. What are the X-rays should be advised in the cervical spine? Epilateral, okay. What are the X-ray? What are the X-ray? See, mount open view. Mount open view for C1, C2. Open up the mount, take the data. 1 point. Number 2, APN lateral cervical spine. Particularly if you possible, pull the shoulder down below so that you can have a better view of the lower spine. Lower junctional cervico-thoracic junction is difficult to delineate because of the shoulder. So you take swimmer's view. Besides, people earlier advised to go for right oblique view, left oblique view, see the foramens. Yes, sir. And again, there is another advice to go for the stability test. Means you do the distracting force and see the exercise to see the translation. But this is a very risky situation, may cause injury. So that is why this actually complete investigation. I told you situations, all the situations, what may happen to the casualty. One group excluded. One group may present with neurological deficit or without neurological deficit. What is the investigation? Investigations are in cervical spine, AB view for C1, C2, AB lateral view of cervical spine. Try to pull the shoulder down to have while you are going for this lateral view. Oblique views are also advised earlier as test view. But stage view are a bit detrimental, sometimes may cause unwanted consequences. So even doing all the investigation also, sometimes not enough to tell us about the injury. In this situation, what's best? Go for CT scan and also MRI. MRI, as I said, is going to tell us about the condition of the PLC and also the intervertebral disc. And CT scan will basically tell us about the small fractures involving on the spine. So that is why X-ray, CT, and MRI all are important from their point of view. Because of the fact to have a better picture idea about the extensivity of the injury to the spine. Yes, sir. So you supposed to have a better idea. So out of all the X-rays, if you are doing the X-ray, what is the most important X-ray? It is the lateral view of the cervical spine. It is said the lateral view of the cervical spine speaks more than 60% of the injury, 60 to 70%. More information you can get from the lateral spine. So out of all the X-ray you are advised, most important X-ray is to go for lateral view of the cervical spine. Okay, sir? So that is very important. Now next point we have to discuss about the X-ray. So these things are clear. So the treatment point I am not dealing with. Basic change initially ATLS guidelines should be followed. Subsequently exclusion of the cervical spine. Do the basic investigation. What are the X-ray? Unjudicious access should not be advised. Your access should be on logic. Yes, sir. So this part. So next, what is the time now? Finish. No. Can you continue? We can continue now. So if we continue, then go for the X-ray. At least what are the X-ray? So for the X-ray, one X-ray at least. There, so in the X-ray, what are the, how you should read the X-ray? How should you read the X-ray? In the cervical spine, X-ray should be order. How should we read the X-ray in cervical spine? X-ray should be read. So we have already discussed that the lateral view is most important view. Most important view, lateral view. So one should give more stress to lateral view of the cervical spine. And if possible, you can pull the shoulder down so that you can have better illumination or better idea at the lower cervical. Okay, one is this. Number two is that how to read the X-ray. At least first thing that there are certain lines are there. This X-ray should be read on the basis of A, B, C, D, S. देखो. A, B, C, D, S. What is A? A stands for alignment. Alignment. Basically, alignment and axis. How? And grossly, how the alignment is. So in the grossly cervical spine, you suppose you have cervical lordosis. Lordosis may be lost alignment. Then in the alignment also, you have four lines. One is called anterovertebral line, one is called posterovertebral line, one is called diastereotomy line, another is called spinous line. Four lines. Know it or do not know? One line is that going from the anterior border of the body. Another is posterior border of the body. Another is also through the joint. Another is the spinous process. Think of the spinous process. These four lines are very important. This four line will tell us about the alignment of the cell. If it is somewhere there is a step, supposing you are tracing the anterojoint line, there is a step there. It means some sort of subluxation dislocation is taking place. Yes, sir. Same is true for the other part also. So these four lines you're supposed to know in lateral view called alignment, anterior, posterior, diastereotomy joint, and also the spinous process. Understood? Yes. One is A. What is B? B is to look for the bones and also base of the skull. B. So B means bone. Look at the shape of the bone. How is the body? How is the joint? How is the spinous process? There may be fracture somewhere. There may be compression. There may be some sort of abnormality. There may be blocked vertebral congenital deformities also. So you should understand this. So B stands for bone. In the bone, you are supposed to look for the base of the skull up to the C7. Whatever is coming in view. Look at the orientation. Are they okay? There may be fracture, there may be horror. Many things may happen. There may be compression of the fracture. There may be burst fracture. There may be congenital deformity also. Block vertebra in the cervical spine is very common. Infective pathology may be there. There may be some destructions of the vertebra. Secondary metastasis may be there. So many things may happen. So you are supposed to look for it. This stands for bone. Very good. On the base of the skull. C stands for cartilage. Means this. How is this? D also says for disc actually. Cartilage means cartilaginous part. Linear part মানে সব কিছু। Yes. A, B, C, D has a disk space actually. Disk space. And also people